Good morning, everyone. I want to thank Dr. Rana and Patty and the entire organizing committee and all of the volunteers who participated to put this conference on this year and the years before. On behalf of the DC Department of Health, I bring you greetings and appreciate you being here. You know, it was 10 years ago, I can't believe actually, it was 10 years ago that Dr. Rana came and said that he wanted to put this conference on and whether the health department would support him. And I believe actually pretty much every year we have supported the conference because we are at an historic time in the history of this epidemic. We have now the tools, the science to be able to end the epidemic, and we're very grateful that now even our federal leaders have taken the next step towards that commitment. In 2016, Mayor Bowser declared that she was going to end the epidemic in the District of Columbia, and we've made progress, but we have more to go. And quite frankly, one of those greatest barriers to achieving this end of the epidemic remains stigma. I'm very proud that the District of Columbia was the second city in the United States to endorse U equals U, undetectable equals untransmittable. And when we because for so many years, people living with HIV have had this burden of being the agents of this epidemic. And now, truly, they are the solutions to this epidemic. People living with HIV who take their medication consistently achieve an undetectable viral load, and they cannot transmit HIV to their partner. Let me say that one more time, and I know you're going to hear it from the next panel, but people who take their medication and become undetectable living with HIV cannot transmit HIV to their partner. That will be the effort to end the epidemic. And we need you, all of you here today, and everyone that you know. If there's one message that I can ask you to take when you leave here today, is to tell someone that you know, someone that you don't know, what U equals U means. Because when we as a whole community can communicate this message, then we can end the epidemic in our lifetime. Thank you so much and have a great conference.
The next is actually a story written by a good friend of mine. She's Indonesian, she's a journalist, and she's been working with HIV for close to 20 years. She's adopted kids with HIV and is there to take care of people with HIV when nobody would touch them. Santiaji Sayafat, I hope you're watching. She has written probably 10 or 15 novels, and she writes regularly about stigma of HIV because she's right there in the trenches living with these people. She's an Indonesian journalist. She has won many, many awards. She cannot be here, but Nana would read one of the short stories, a real story written by her. Nana?
Hello, good morning, everyone. Okay. Stigma defeats motherhood, fatherhood, and kinship. When he learned the test results were reactive, meaning HIV positive, tears rolled down the face of 24-year-old Rian, and his face became tense. He repeatedly asked the meaning of the word reactive, even though it had been explained repeatedly. I explained that in his body there was the HIV virus because of his unsafe sexual behavior. How do I explain HIV and AIDS in detail so that Rion understood well and so that it did not cause him fear, so that it did not make him stressed? I repeatedly asked if he understood me, and he said yes. So he was very understanding. Rion performed the test on February 2nd, 2008. He arrived just a week later and was ready to receive the test results. Baffled by the results, he asked, "What should I do?" I told him that he could no longer engage in risky behavior and he had to live a healthy lifestyle. However, he still had to think positively because by thinking negatively a lot, it will cause damage to his health. Do not assume the death is close because of your HIV status. The world is not over, but it is the beginning to organize a better life. Many people with HIV and AIDS remain empowered by living a healthy life, remain empowered by healthy living and antiretroviral therapy. At that time, Rion said that he was not ready for ARV therapy and requested that the test results be notified to Nina, not her real name. The decision to open his status made him suffer. Nina told her neighbors that Rion was HIV positive and its transmission was very easy. Through mosquito bites, the air, using the equipment he had used. It was a deadly disease. As a result, Rion was evicted from his aunt's house, his mother's sibling, that he had lived with so far. So he chose to live in an empty house while working as a construction worker. Although she had been given an understanding of HIV transmission, his aunt still would not accept Rion. So on May 17, 2008, Rion decided to return to his aunt's house, his father's sister this time, who lived in another city, who had cared for him since he was a child. Before leaving, I went back to counseling him and recommending antiretroviral therapy immediately. I also asked him to pray so that his heart and soul would be calm. According to him, he had prayed. He just didn't memorize the reading. I took his hand, I looked into his eyes. I said, "That's fine. The most important thing is prayer. Whether it's accepted or not, it's up to God." He later told me that during his childhood, his parents divorced, so he lived together with his aunt who had no children. After he was a teenager, he lived with his mother in another city. On Friday, July 10, 2008, I saw Rion. I could not believe how thin and pale he was. He was helpless. He returned to my city after his health took a turn for the worse. According to him, he felt ill because he always thought about the attitude of his aunt, who kicked him out because of his status and considered him a family disgrace. That night, residents gathered and his aunt locked the door. After evening, Rion entered without permission. Everything that Rion touched was washed by his aunt. Even the cutlery was thrown away. I then gave a detailed explanation of HIV and AIDS, giving confidence that his existence would not make them infected with the virus. But his aunt still did not want to accept it for reasons of fear of contracting the virus and disgrace to the family because Rion was HIV positive. I persuaded Rion to be hospitalized because he tried to kill himself after no one wanted to accept him for the fear of Nina's story. At the hospital, it was the nurse who cared for him when I was not there. After 6 days in the hospital, Rion was discharged in better condition and started ARV therapy on July 16, 2008. Because his aunt did not accept him, Nina invited Rion to stay with her, perhaps very aware of her mistakes. But the wrong understanding about HIV at an early stage, that the HIV virus is easily transmitted and deadly, eliminates motherhood, fatherhood, and kinship. They still do not treat Rion with love for various reasons, even though I provided them with facts that HIV and AIDS in a detailed language that was easy for them to understand. So, Saturday, July 19th, 2008, Rion was treated again. This time, Nina took him to the hospital. His condition worsened. He was thin, with a hemoglobin level of about 5. The doctor support treatment and I always provided him with support, bought all the food he wanted, for example, KCF and other favorite foods. Rion's desire to be cared for by his biological parents could not be realized. The stigma about HIV and AIDS was so much stronger for them that they ignored their roles as mothers, fathers, siblings. Rion's aunt and cousin visited him once, and that was because I forced them. Before attending a week of training in another city, I met with him. At that time, his condition began to improve. His hemoglobin level was about 10 this time. He asked me to buy him watch, clothes, and trousers. During my training, I contacted him through my friend, the HIV/AIDS counselor, and sometimes the nurse who cared for him. I told Rion that I had bought everything he wanted and I would come back soon. He laughed and said he would get better soon. On my way back to my city at 12 a.m. on Saturday, July 26th, 2008, my advisor friend contacted me and said, Rion was dead. My heart was broken. The shadow of Rion, who gladly accepted the souvenirs I bought, was lost in my mind. Early in the morning, I went to his aunt's house and contacted his parents, reporting that Rion had died and his body was in the hospital morgue. Until noon, no one in Rion's family came to take care of his body before it was buried, making me furious with his family. In the afternoon, Rion's family came to treat the corpse in the hospital. Since morning, the hospital took care of Rion's body. Rion's death is proof that the HIV virus overcomes motherhood, fatherhood, and kinship. His father, mother, and brother never came to see him until his death. His father saw him after he died. What is needed by people living with HIV/AIDS is support from parents, relatives, friends, partners, community, and medical personnel. Stigma and discrimination can make a person die slowly. May Rion's sins be forgiven, and God give him the most beautiful place he has never met in his life. Thank you.
Linus, I know Linus is watching in Cameroon. Linus, I think it's good afternoon there. Linus Mbe is part of our organizing committee and has helped us organize this conference every year for the last 5 years. He's been here twice. This year, with his meager savings, he applied for visa, but almost I think none of our African applicants who wanted to come to attend this conference could come. None of them got visa. Unfortunately, they lost $200 each for visa application. We have a small, very short welcome video from Linus. Could we play Linus' video now? And Hajra's video will play later.
Annual International Conference on Stigma with Team Youth Power Up for a Stigma-Free Future. I am Linus Ayango Mbe, Organizing Committee Member of International Conference on Stigma, founder and CEO of an NGO based in Southwest Region, Buea, Cameroon. I have been Organizing Committee Member for the past 5 years and have attended the event in person in 2015 and in 2017. I'm sorry I will not be part of the event in 2019 due to the fact that I was denied a visa at the US Embassy in Cameroon. But that will actually not stop me from advocating on stigma. In 2020, my organization will be organizing a conference in Cameroon on HIV-related stigma. So I'm calling on people of goodwill to support this initiative so that together we can eradicate stigma in the community and the world at large. And also I want to thank you for your participation. I thank especially to the organizing committee team for their effort and the initiative. Special thanks goes to Patricia Austin and the conference director. Thank you very much and enjoy your stay with us.
Good morning again. I think it's still morning. I want to thank Dr. Rana and all of our guests for the welcoming greetings. We're going to start our first AM session. If you were on that session, would you please walk through here and through to the stage. Our moderator today is Dr. Warren Miller, an assistant professor at Rhode Island College School of Social Work. His research and clinical focus includes HIV/AIDS and social work practices, and HIV stigma and the use of spirituality. He is also a Howard University alum. HU. Please welcome our moderator home and to the stage, Dr. Miller.
Good morning, everyone. I know we're going to good morning you to death, so you're going to hear it a couple of more times. Good morning. That wasn't energetic enough for me. Good morning. Good morning. Yes, thank you. Thank you and welcome, and thank you for having me today to be able to moderate this session. As Lisa shared, I am Dr. Warren Miller. I'm an assistant professor at Rhode Island College School of Social Work. I went to Howard University School of Social Work, HU, you know. So I'm back home, and I appreciate every moment and chance that I can come back to be able to work and lend a hand to be able to talk about HIV, particularly stigma. Right now, my current work is focusing on racial macroaggressions around for aging gay men living with HIV and how that impedes successful aging. And so my colleague and I, who are currently working on that project, recently received the institutional grant to be able to conduct that research. So I'm looking forward to that work and currently working with you all today. So without further ado, I'm going to introduce our distinguished panelists today. Their biographies are in your program, and I won't read them directly, but I'll introduce their titles, and each one of them are going to present for about 15 minutes on their current work in their research, and then we're going to have sort of sit-down living room chat, so to speak, around the particular topic of reducing, research leading the way, becoming youth-centered to reduce stigma for a HIV-free future. That sound all right with everybody? Yes. All right, great. So first we have Dr. Laura Nyblade. She's a senior research health policy analyst at RTR International, right here in Washington, D.C. Dr. Nyblade? Hi. We also have Mr. Murray Penner. I hope I'm pronouncing Penner right. Penner, oh, thank you. Mr. Penner is Executive Director of Prevention Access Campaign North America. And we also have Dr. Derek Dangerfield, who is, hi. Dr. Derek Dangerfield, who's an assistant professor and researcher at Johns Hopkins School of Nursing. So we're going to start with our individual presentations first, and then we'll move into our living room chat. So we're going to start with Dr. Nyblade. Let's give her a round of applause, please. Thank you.
Good morning, everyone. Let's see if I can figure out how to make this work. So I'm really honored to be here today. I spoke at the very first conference, which was 10 years ago, and I've been here multiple times. And I'm glad they invited me back, because last year I was supposed to speak and I lost my voice. So I couldn't be here. So it's a real honor to be here today, and also to take my hat off to all the people who organize this conference every year. I know it's a lot of work. I'm going to talk today about some work that I've been leading in both Ghana and Tanzania, but I'm going to focus on Tanzania today because of the topic of our session. I've been working on HIV stigma and other stigmas for over 20 years now, so I'm aging myself a little bit, and really focusing both on basic research, but really on research to improve measurement and programs. So I've spent a lot of time working in healthcare facilities. And as we heard this morning already, we still have a lot of work to do in healthcare facilities. As Dr. Rana mentioned, I'm always shocked. We do a lot of surveys in healthcare facilities across the globe, and we still find that healthcare workers, including doctors, are still afraid to touch people living with HIV. Here we are 30 plus years in, and we still have this, and it translates directly into stigmatizing avoidance behaviors. So as Dr. Rana said, we still have a lot of work to do. But the good news is that we do have programs, we do have tools, and we need to advocate for these to be used and scaled up. Again, as Dr. Rana said, we spend a lot of money on clinical trials. We spend very little money on stigma reduction activities. Yet we know that this is at the heart of our challenge. So we should reduce stigma because it's a fundamental human right violation. That's the bottom line, right? But we all live in the reality of where the funding comes from, which is our medical community. And so in working around HIV stigma in particular, our focus is really on how do we get to that ultimate viral load suppression. And I put up this framework because I want us to focus on, I guess that's your left, what I call the immediately actionable drivers of stigma. So in 20 plus years of working on stigma, when you bring up the word stigma with programmers, policymakers, you get this kind of glaze that happens, right? This is too big, right? It's too complicated. We can't do anything about it. That's sort of the reaction you get. And the reality is that's not true. There are things we can do. And yes, while we're working for that larger social change, which is ultimately what we need, there are things that you can grab onto now, in the here and now, right now, we call them immediately actionable drivers, that can make significant change, we've learned. So in the health facilities, but also in any community that we've worked in and with any target population, we've learned that there's 4 things we need to address. The first is the fear of contracting HIV. So as Dr. Rana mentioned this morning, this comes out in visible sort of separation of dishes, physical isolation, social isolation of people living with HIV. That fear is still something we have to address, and it's rooted in our history with how we sort of our public health campaigns that were very fear-driven in the beginning, and that fear has sustained over time, even though we don't use those fear campaigns anymore. But also in just understanding. So we still, and I'll talk a little bit about how you actually get at that fear and change it. What we've learned is if you do knowledge surveys, everyone will tell you how HIV is transmitted and not transmitted. But if you dig a little deeper, you'll see that they don't quite believe it. And why do they not quite believe it? And what can we do to address that particular fear and get people over it so that they're no longer afraid of getting HIV in ways that you cannot get HIV? The second is awareness of stigma. We all stigmatize. When we do it on a daily basis, we're just not aware that we're doing it. And what we've learned over the years, and particularly with healthcare workers, is that their intention is not to stigmatize. They simply are unaware that they're doing it, and they actually think they're doing the right thing. So for example, we have a lot of use of double gloves in the countries that I work in. Why? Because of that fear of transmission. But what does double gloves do? It marks a person. It marks a person as different. It marks a person as dangerously different. And it discloses their status to everybody around, other clients, other health providers who have no need to know. So awareness, it's not rocket science, but we often don't give people, and in particular healthcare workers, the space to really understand what stigma is in very concrete terms. When I say this, when I use these words, or when I do this, I am stigmatizing, and it has these consequences. And something as simple as a safe space to understand and realize that can make real differences in the way people deliver care. So that's the second sort of driver that we, immediately actionable driver that we address in our programs. The third is our attitudes. So again, Dr. Rana gave an example this morning, and we know that our attitudes, whether we like it or not, often unconsciously influence how we treat others and how we deliver services. We work in a lot of conservative countries. We don't go in asking anyone to change their religious beliefs. What we do is we ask people to reflect on what their attitudes and values are and where they come from and how they might influence the way they treat others and deliver care. And that can be very powerful. So it's an important line to walk, because if attitudes are often based in very deep-rooted values and how we were raised, so it's very important to walk that line, but it can be walked and it can make a big difference. And lastly is our institutional environment. I work a lot in healthcare facilities, but we've also seen this in communities of faith. Are the institutions actually providing the right environment for healthcare workers to actually deliver stigma-free services? So thinking about that, are the right policies in place? Are they enforced? We're not saying there's no risk of infection transmission in healthcare facilities. Do people have what they need in terms of safety supplies? After one of our trainings, I had a OBGYN, and I won't name the country, come to me and say, you know, I do stigmatize and I do discriminate because I don't have enough gloves to deliver every single woman who comes into my clinic. So I actually test my clients for HIV without them knowing, so I know which clients I need to use gloves with because I don't have enough gloves. So that's an institutional sort of issue around providing the environment that allows healthcare workers to provide. So we focus on those drivers because those drivers are what leads to the stigma manifestations, which then follows through the cascade. It keeps us from wanting to get tested for HIV, it keeps us from linking to care, keeps us from returning to care, from adherence, and that has that ultimate goal of making us healthy. So stigma, those drivers are really important. So what I want to share with you is a approach and a process and a set of tools that we have now for addressing stigma in healthcare facilities. And this work is being done in multiple places. So I'm going to share with you some work that was developed under the Health Policy Plus project, which is funded by USAID and PEPFAR. And this work has been done in Ghana and Tanzania, but I'm going to focus on Tanzania because our panel today is around adolescents, and we had an additional focus. The focus was HIV stigma reduction, but we also incorporated a focus on reducing stigma towards adolescents who are seeking sexual and reproductive health services, which in the countries I work in are a highly stigmatized group because our attitudes, right? Young people shouldn't be having sex. So why are they coming in here for sexual and reproductive health services? And that plays out in the way we deliver services. So we focused on that. I want to say that the work I'm presenting, both specific to Tanzania, but this is a global process, so there's many other countries and groups that have contributed to the conceptualization and also the testing and evaluation of this work. But particularly in Tanzania, just wanted to acknowledge all of the people who made this work possible and for me to stand up here and share it with you. So we have a three-stage approach, and I'm going to focus today on the middle part, which is the intervention, actually how we do this. But I want to say that the assessment, the research that goes around it, the baseline and end line is very important, both for us to be able to see if we're making any difference, but we find that the baseline data is very important in catalyzing action and getting healthcare facilities to actually want to do something about stigma. So often the reaction we get is, there's no stigma in my healthcare facility, it's the one down the road. And we're like, well, that's great, let us measure it, and you'll see that. And of course, what comes back is, no, actually there is stigma here. And with what we do with this data is that, well, first of all, we have healthcare workers and in Tanzania, youth work with us to develop the questionnaire. So we have a global questionnaire that's easily adapted and used, and we go through a process in country of bringing together stakeholders to adapt that questionnaire so that it's relevant and also that there's ownership of the data that's being collected. And we bring the data back to the health facilities in a workshop setting where then the managers of all the different departments in the overall facility, along with clients, sit and actually analyze the data and sort of validate it and talk about it and start discussing what needs to be done to be changed from what we see in the data. So the data, the baseline data collection is really part of the intervention. It's a really important part of the intervention. The middle is the intervention, which I'm going to talk to in more detail, and then the end line is the evaluation, and this is what we gives us our evaluation data. It's the same data we collect at the beginning with some additional data. So a really big part of this intervention is building capacity within the health facilities to address stigma. So this is not something that's coming from outside. This is something that's developing from within the health facilities. And this is really important, both for ownership, but also for sustainability and impact. So the first thing we do is we work with the facility management to identify health workers and clients who would make good participatory stigma reduction trainers. So we have a few criteria around what that is, and we work with the management to sort of put out an advertisement and encourage people to apply. We then train those people who have been selected, both health workers and clients, together to then be the leaders for the stigma reduction work in the health facilities. So in Tanzania, this was health workers and then clients, both adults living with HIV and adolescents living with HIV. And we had really, really dynamic adolescent trainers. And they made a huge impact on the intervention. So then these groups are trained together. So they deliver training to health workers, to their peers as training teams. So it's health workers and clients who train together. And this is important because within sort of the stigma dynamic that happens, healthcare, when you go to seek healthcare, there's a power dynamic, right? It's always, if you're the client and you have a healthcare worker, they have power over you. And it's really important to sort of create spaces for interaction that are outside that power dynamic. So this is what this training does. And it also flips things, right? Because here's the client who's actually training the healthcare worker. So that dynamic is an important part of this approach. And having youth as part of that has been very important in Tanzania. The people who are trained, they go back and they deliver the training to their peers. And we train all healthcare facility staff. We know from years of research that stigma often starts at the gate. Sometimes in the places I work, it's the guard, right? You don't even get past the gate because of the way you're treated at the gate, or it's the receptionist. So it's important and we call ours a total facility approach, meaning that we involve the whole facility. So it's everybody in the facility. So everybody gets trained in this facility, and we train different levels of staff together. So we train guards, nurses, our cleaning staff alongside our surgeons and our head nurses. We were told you could never do that. You can't mix those groups. And we're like, okay, but let us try. It worked beautifully. And what we heard from management was that it completely changed the dynamics of the staff in the facility because there was stigma happening between the different levels of staff within the facilities. And so it changed the dynamic. And it might sound hokey, but one of the first things we do is when people come in for the training is we have them make paper hats, and they write on the hat all of their identities. You know, I'm a mother, I'm a sister, I'm a nurse, I'm a daughter. You put all your identities on your hat. And we talk about those identities. Then everyone takes their hats off and puts it in the corner, and we're like, okay, within this space, those identities are gone. right? You can take your hat and put it on when you leave the room, but in this room, your identities are gone. Everyone's equal. And it's amazing, within a couple hours, nobody's being called doctor anymore. Everyone's on a first-name basis. So there's also advantage to this in terms of how it changes the dynamics. We also heard from staff in the larger hospitals that because we trained people, we mixed people across departments as well as levels. And part of this was logistical, like how do we do this without, this is a 10 to 14 hour set of training. How do we do this without disrupting clinical care? And part of that is by taking people across departments and levels. But we heard from people like, I can get better care now for my clients because I actually know that person over in the radiology department. I actually have a connection with them now. I can call them up and they can help me. So it really changed the dynamics. Okay. So this is what the training looks like. And what I just want to point out is, if you look closely at some of the topics, you'll see that it's actually addressing those actionable drivers that I talked about. So we're working on awareness. We do this in different ways. For example, through pictures. We often will draw maps of the facility or actually do a walkthrough and have people describe what is happening in each department and how stigma is happening in concrete terms and what can be done in that specific area. We talk about the fear of contracting HIV. And what we try to figure out is, what are people actually afraid of? And we find that oftentimes it's sweat and it's saliva. And so we talk about and go into detail about why you cannot contract HIV through sweat or saliva, and do that in very concrete terms. So trying to, with the fear, what we've learned, whether it's with healthcare workers or other in communities, is understanding what is the specific mechanism that people fear, and then helping them understand why they do not have to fear that. We do a lot of building empathy, and we do this through contact strategies. So we know both from HIV stigma, but also from mental health stigma and other stigmas, that the most effective way to reduce stigma is through contact. Once you know someone, it's very difficult to stigmatize or discriminate. And so that's one of the most effective ways. So we build different ways that contact happens within this training. Obviously, the first is that health workers are being trained by people living with HIV. The second is that we often bring in a panel who then talk about their experiences, both negative and positive. The other thing we've learned is that it's important to model the kinds of behavior you want, not the ones that you don't want. If you tell people don't do this, they're not going to listen. But if you show and reward what the behavior should be, you'll have more effect. So this curriculum is available online. If anyone's interested, we have a couple different variations of it that have been adapted for different countries. So in addition to the training, we have sort of other things that have happened in these facilities. And what happened was, after the training, so everyone got training in these facilities pretty much. We trained between 70 and 90 and 100% actually in some of the Tanzanian hospitals of staff. And we actually had challenges because we had a plan to train between 50 and 70%, and we had management in the first trainings. And after the first trainings, they came to us and said, no, you have to train all of our staff if you want to continue working here. So we managed. But a group of health workers emerged kind of organically from this training, and they wanted to do something more. So we worked with the health management to actually form formal groups that they would support, called stigma champion groups. And they developed their own sort of low-cost stigma reduction activities that they carried out in their facilities. And we gave small seed grants to support that, but a lot of the work has continued past the evaluation, and they found lots of creative ways to do stigma reduction at no cost in their facilities. And this woman here is actually she's the receptionist in the outpatient department in one of the facilities. And before the training, she was a pretty gruff, challenging woman. And after the training, she just became this kind of outward, welcoming person. And she embroidered on her smock, "Ask me questions." Before, she wasn't going to entertain any questions. And now she actually, so that's a low-cost way to do stigma reduction. And this was her her individual contribution. As part of the training, after each module, we have the group sort of talk about and write down what they as individuals can do to change based on what they've learned in that module, but also then what they need to do as a group or as an institution. And that becomes kind of a roadmap for the facility in terms of how to do stigma reduction. Both facilities in Tanzania went out and negotiated free airtime with radio and TV, and that continues to this day. And there's actually a nurse and an adolescent who sort of run a show on the local radio to talk about stigma and HIV. It's all on their own initiative after this training. So I think if I've learned nothing, it's that there are a lot of stigma warriors out there. You just have to give them the tools they need. So I know I'm running out of time, so I'll just tell you this is what we measured. We have really good measurement tools, so don't let anyone let you use lack of measurement as an excuse for not doing stigma reduction, because we know how to measure it. That was an excuse for a long time to not fund stigma reduction activities, was, well, we don't know how to measure it, so if we put money there, how will we know that we're having any impact? That's not the case anymore. So we measured HIV stigma, we measured stigma towards youth who are seeking sexual and reproductive health services, and then our evaluation design, this was operational research, so it wasn't as strong as we would have liked, but we had pre-post baseline surveys. It was a census sample, everyone we could find that week in the health facility. And then we had a convenience sample with clients. So I just want to show you a little bit about some of the numbers at baseline, just a snapshot. We have reports if you're interested. So you can see, and I'm focusing this on the youth results since our panel is about youth, but we also have this for people living with HIV. You can see the number of stigmatizing attitudes towards youth, percentage of staff. So you can see we have very few who have no stigmatizing attitudes towards youth. And then we have sort of in the middle, those who had 1 to 2, and then we had a clump who had 3 to 4. So we really needed to do something about this. This is from the perspective of clients. You can see again, youth are reporting the highest level of experience discrimination, and this is 1 of 9 measures in the past 12 months. So you can see that adults are also experiencing it, way too high, but that youth are experiencing it at higher levels. So overall, we found that it was effective. We had significant reduction in those drivers I talked about, as well as the manifestations of stigma. We had both clients and staff reporting that things had changed in the facility. And then as I talked about, there were benefits for staff. We had a doctor in one of the facilities who actually disclosed that he was living with HIV after the intervention. He had never shared that he was living with HIV in his facility. And this is from a youth client and one of the ones who's talking about the changes that youth are experiencing. We don't get scolded anymore. One of the things we see as a manifestation of stigma towards youth is really harsh language and scolding and things like that. So that's changed. These are just to give you some pre and post. And you can see these are stigmatizing attitudes towards different groups of people. And on the far, I guess that's right, that's the attitudes about sexually active youth. You can see that we still have a long ways to go, but we did have significant declines baseline to end line. We measure observed discrimination. We've learned over the years that if you ask a healthcare worker if they've denied someone care, they're not going to tell you they denied someone care because they know that that's not the socially appropriate response. However, if you do ask them, have you seen this happen in your facility in the past number of months, you will get a potentially more honest answer. Again, that's not an ideal measure because they could all be reporting on the same instance, but it gives you a bit more sense of what's going on in the facility. So this was observed discrimination in the facility. And you can see that unmarried pregnant adolescents, they were at the top of the chart at baseline. So again, the importance of addressing not just HIV stigma, but some of these intersectional and underlying stigmas that often come together. So what are the key elements? It's based on evidence. This is based on work we've been doing for 20 years. We have really good global measurement and intervention tools that are easily adaptable. They need to be contextualized, but you can do that pretty easily. The recognition that all staff have a role to play, it's not just clinical staff. Everyone who interacts with clients is important and has an important role to play in stigma reduction. Obviously, your facility management engagement is really important. If the bosses won't let you in and aren't supportive, nothing's going to change. It's important to be data-driven. That gives you a lot of power, particularly at baseline, to say, yes, we need to do something about this. And most importantly is the building of capacity of staff and clients to address stigma in their own facilities. This has been really important, both because it leaves capacity after we leave as a project, but also because it seems, if you're taught by your peers or you're in a participatory process with your peers, it's much more likely that you will want to change and take ownership. And I think this sister in charge in Invomero really says it all. She said training health facility staff as facilitators, and I would add clients there, led to much better results because they were our own staff and they understand what we do. I had one person stand up in a dissemination meeting and say, you know, the difference with this intervention was it wasn't some big shot outsider who came in their 4x4 from the capital city to tell us what we were doing wrong for 2 days and then left. These were our own colleagues who understand our challenges and our struggles, and they were here with us, and we did this together, and that is what made the difference. So I would say that's the most important part of this. So I just want to end by saying we don't have any more excuses. I've heard all the excuses over the past 20 years. We don't know enough about stigma to address it. It's too culturally specific. That's not true. It's a fundamental human social response, and there might be differences, but there are more of nuance than core. So we have no excuses on that front. We don't know how to measure it. We know how to measure it. We don't have intervention tools. We know that. We don't know if our interventions are effective. We know that. We have no more excuses. So go out there and advocate for stigma reduction. Thank you.
Thank you, Dr. Naible, for that important work. I will call Mr. Murray up.
Good morning. It is great to be here. It's really an honor. I'm humbled to have the opportunity to stand before you and talk today. My pronouns are he, him, and his. And let me start by just acknowledging that I stand here with a substantial amount of privilege. And I think we sometimes don't recognize our privilege. Some of us have far more than others, obviously. But I'm standing here and absolutely am committed to using that privilege to fight the injustices that I haven't experienced necessarily. And I invite all of you to call me and hold me accountable if I don't live up to that commitment. I remind my work colleagues about this all the time. It is so important to make sure that we are present and that we are acknowledging who we are and what we have and what we can do. And so I want to start by just making sure that you all know you can call me on it if I don't do it right, and that is really important to me. I also want to start by saying that, and if you can bring up my presentation as well while I'm talking. I also want to talk about words and how words matter. It's important when I'm going to start talking about U equals U, the words we use are so important. But one of the things that I often hear is disclosing one's status. I think the word disclosure in and of itself makes it seem as though there's something wrong, and so I like to use the word sharing about my status. I'm HIV positive. I've been living with HIV since 1986, and unfortunately I have experienced a lot of this HIV stigma that we all hear about. It's prevalent. It is so prevalent. You mentioned it, Doctor, when we were opening up about how prevalent stigma is. It's all around us all the time. I mean, things like eating after someone or touching someone, things that we thought or we should be way past are still very present in what we are working on. So in my work with the U equals U campaign, it's really difficult to get to that science and that research when we've got such basic stigma that we're still trying to overcome. And so we know how damaging HIV stigma is and that it does kill people. Sometimes it's not HIV that kills people, it's the stigma that kills people. And so we have a lot of work to do, and erasing that fear and erasing that discrimination is so important. I am going to talk a little bit about the research because I know that's the topic of this panel. I'm not going to spend much time on the research of U equals U because there's so much to do with that research. But I do want to touch on that and make sure that you understand that it's coming from science. This movement of U equals U, undetectable equals untransmittable, is coming from science. Michael introduced it and said that we really have lots of opportunities to move forward with U equals U. And I wish I could talk about one piece of research that my organization is working on. Unfortunately, we're under an embargo, and we are releasing the information on Monday. But it is also very telling about some behaviors and knowledge and stigma around young adults in the U.S. And so we know with the epidemic in the U.S. being majority diagnoses among young people, that we need to be moving this conversation to young people. Young people have access to all of the information. It's all there, but it's not reaching them, we're finding in many instances, in ways that they understand and can incorporate it into their lives. So we have a lot of work to do. So let me move forward. People living with HIV who are on treatment and achieve an undetectable viral load, cannot transmit HIV to their sexual partners. Now, an undetectable viral load means that your virus, if you're taking medication, in your body is so low that it cannot be detected by tests, or it can only be detected at a certain level. And for the purposes of our U equals U campaign, the studies were based on 200 copies per milliliter. So if you're under 200, you're considered undetectable, and I'll talk a little bit about that in a moment. First wanted to play a video of Dina Bonds from the 2018 International Conference. She's a very influential trans leader in the international movement, and let's see if we can get the sound to work here.
Transmittable, or U is U, message to become standard knowledge worldwide. It needs to sound louder every day, as this eases the burden of stigma and self-stigma of people living with HIV. It will save lives. It will reduce suicides and murders on trans sex workers especially.
So I think she sums up really well. It will save lives. There we go. So in 1996, we knew with effective treatment that we could start saving people's lives who were HIV positive. And today we know that it means even more than that. It means that we can't pass on HIV to our sexual partners if we're undetectable. Now, I do want to stop real quickly and just talk about if we are undetectable, because there are many, many barriers to getting to an undetectable status. Many times, just simple access to health care. And so I think we need to recognize that we are not always, even though we have these tools, not everybody can access it. And if you look at black and brown people living with HIV, many times they are disproportionately impacted and have less access to those tools. And so to say that everybody can get to this because we have the tools is completely incorrect. We have so much work to do related to access so that these tools can benefit people who need them. And I'll talk a little bit more about the argument, the public health argument that we use for U equals U in a moment. So where did it come from? In the 90s, we knew that mother-to-child transmission, antiretroviral therapy, was working to prevent mother-to-child transmission. That was the predecessor to U equals U. It was sort of the early hint that medications worked. In 2007, we saw the treatment as prevention movement, if you will. And in 2008, the Swiss came out with this statement that said, if you're undetectable, you don't transmit the virus. And everybody was like, no, 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 you can't say that. That is not true. No, no, no. Stop. Stop the press. We can't be talking about this statement in 2008. Well, guess what? Fast forward to 2016, and we started seeing studies that were confirming this. And let me talk about those here in just here a little bit. So there's 4 studies, HPTN 052, Partner 1 and 2, and Opposites Attract. These were studies with approximately 4,200 couples, serodiscordant couples, so 1 positive, 1 negative couple. They studied 125,000 condomless sex acts. 120, that's a lot of sex, right? So they studied 125,000 sex acts without condoms. And guess what? There were 0 transmissions, linked transmissions, and that's an important caveat. They are linked transmissions because there were some transmissions that occurred in the study, but when they followed where the transmission came from, it was not from the HIV positive individual who was undetectable. So it's important to note that there were some infections, but not linked to the HIV positive individual who was undetectable. So that's amazing. In 2016, that research was starting to come out, and Bruce Richmond, our founding executive director at Prevention Access Campaign, said, wait a minute, how come people don't know about this? We need to start publicizing this. I do want to point out that the research indicates sexual transmission and not transmission related to breastfeeding, chest feeding, or needle sharing. We do, however, know that antiretroviral treatment helps individuals. So just because it doesn't necessarily apply to those activities doesn't mean that people who are breastfeeding or people who are using drugs don't benefit from treatment. We also do know that it greatly does reduce the risk of transmission. We just can't say that it is 0 transmission risk. So it's an important thing to note. Just a couple of basics before I go on about U equals U, treatment, labs, connection. Those are the important components of U equals U. You've got to be on treatment, you've got to monitor your labs, and you've got to stay connected to care. I also went through these, the 200 copies. U equals U is about sex. U equals U only prevents HIV. It does not prevent STIs. So it's important to remember, if you are working to prevent STIs, you need to use condoms. There are HIV disclosure laws, there's that word disclosure again, that need to be taken into account. And I already mentioned, if you cannot achieve a viral load, undetectable viral load, or you don't achieve an undetectable viral load, it doesn't negate your value. You're still a human being, you still are, a part of the world that needs access to services and health care, et cetera. So viral load does not equal value. So why is U equals U a game changer? Obviously, it transforms our social, sexual, and reproductive lives. It dismantles HIV stigma. The topic of this conference obviously is really important. It encourages people to test, and it should add incentive to start and stay on treatment and stay connected to care. And then finally, it does provide that strong public health argument. We know that if we can get everyone to an undetectable status, we're going to end new transmissions, and so, or greatly reduce them. And so that universal access to care and treatment is so important as part of the U equals U movement. Already talked about this, and I'm going to start moving pretty quickly because I know that we have limited time. So we didn't know about U equals U. There was a lack of knowledge about the research, lack of expertise and authority to actually draw conclusions. There's a lot of paternalism about this. It's like, oh, well, I know what's best for my patients, or I know what's best for the people I'm working with, and I don't think they'll benefit from U equals U. So there's been this whole paternalistic attitude about whether or not people should know about U equals U. And then in general, there's just a lot of resistance to change. So we found that science doesn't have a publicist in this case, and so we needed to do something about that. So why did we need it? I've already talked about that. People have the right to accurate information. People need the right to the information about what's happening in their bodies. And so we took this on. The Prevention Access Campaign came together with researchers and with scientists, and I'm trying to advance this. Okay, keep going. It's a little slow. We came together with the researchers and scientists. We brought activists into the fold, and community into the fold, and people living with HIV in, and came together with a consensus statement in 2016. We rallied around this consensus statement. We did a lot of advocacy. We brought the federal government into the conversation to get them to start to change the language about U equals U. There's the activists. We got New York City to sign on as the first health department. Michael already mentioned Washington, D.C. was the second health department to come on. We got some major organizations involved. And pretty soon we had a consensus statement. Where are we with that today? It's worldwide. It is amazing the movement that we have taken with this U equals U campaign. We have Dr. Tony Fauci from the NIH, the director of NIAID, saying the science really does verify and validate U equals U. We got the CDC to say effectively no risk. Now, CDC does not say no risk in their written publications, but all of the federal government officials who are working, Michael mentioned the federal government is behind this effort to end the epidemic. They are all saying there is no risk. So despite the fact that CDC says effectively no risk, it is no risk. And effectively actually means actually no risk. And so we were very happy with that language. CDC also has, I'm going to go back a moment. This thing is just a little bit touchy. There we go. CDC also now has updated their risk assessments to say it's 100% effective if you have an undetectable viral load in preventing HIV. So they're saying it without them saying it in their words. It is 100% effective. They've also authorized flexibility among grantees about U equals U, and Dr. Fauci also said that U equals U is the foundation of being able to end the epidemic in the U.S., well, across the world, actually. So the U.S. U equals U consensus statement is now signed on by 940 partners in 99 countries. We need that 100th country, so I might be hitting some of you up about signing on. And we've got jurisdictions in the U.S., 15 of them, state health departments, almost 30 local health departments, and then we've got several international governments that have signed on to the U equals U movement. Here's the D.C. The sign-on in 2017. The Mayor Bowser on the right. I think Michael's in that picture too. Here's the New York City campaign right now that they are working on, and New York State campaign, which is really amazing. What I will say is not everyone uses U equals U in their promotions and campaigns. Need to be saying it whatever works for whoever we're trying to reach. And there's been a lot of research, and there's been a lot of different ways to say it. Can't pass it on is one, can't transmit is another. We're seeing some very creative ways to move forward with that. I'm just going to move through these really quickly. This is Zambia. It's pretty incredible. This is Ireland. These are students in Ireland who came together to do a U equals U. Shoot. There we go. It's pretty cool. We've got another one here. This is a dance party in Osaka, Japan. So we've got some very creative things that are happening. So I talked about words mattering, communication. This is really important, and I'm going to move through this quickly because I'm out of time. Language matters. It's important to talk about risk in ways that are appropriate for people living with HIV. We like to say the words on the left: can't pass it on, can't transmit, no risk. versus negligible or greatly reducing or extremely unlikely, because those have sort of a wiggle room. And if you are undetectable, you do not transmit the virus. And so we don't want to imply to people that they have things to worry about. We're trying to erase the stigma and erase the worry and the fear that people have. So we like to use the words on the left column. We don't like to use erasers like, I believe in you equals you, but maybe you should use a condom just in case. You equals you is not it is not necessary to use a condom. If you're in a monogamous relationship, serodiscordant couple, I'm in a monogamous relationship, my partner is HIV negative, and we don't use condoms. I'm going to be just really honest about it because we don't have anything to worry about. Now, if you are not in a monogamous relationship, you might want to use condoms to prevent STIs. I think that's really important to point out, or unwanted pregnancies. Or if the HIV positive individual is struggling with adherence or having issues with undetectable status, or if you just want some security and agency with your body, you can also clearly use condoms or PrEP. And so there are options available. The important piece is to educate and to give all the tools to the individual so that they can make the decisions that are necessary. We also don't like to say, you're only as good as your last viral load test, because that's just like, sort of like, well, then, what do I do if I'm only as good as my last viral load test? We do know from the research. I can say definitively, I've been on antiretroviral therapy since '96 when it came out, and for the last 10 years, I've been undetectable, so I know that it works. I've got that confidence. Now, there are times when, like I'm in the middle right now of going through a medication change. Well, it's important to be aware of that and make sure I'm monitoring, staying connected to care, and monitoring my viral load to make sure that I'm still undetectable. There's a lot of others here. We don't want to, again, stigmatize people if they are not able to achieve an undetectable viral load. I think that's really important. Treatment is a personal choice, and it's something that some people are not comfortable with for whatever reason. Sometimes it's not appropriate for them to do it in their environment. All people with HIV have options for safe sex. Now, that doesn't necessarily always translate to you equals you, but it is an option, and people need to know about that. And again, I want to come back to those structural barriers and those treatment access challenges that many people have. We need to remove those barriers to achieve universal access to care. Prioritize you equals you. We always tell agencies to put it up front and be clear about it versus burying it at the bottom of a paper or on the back side of the website or something to that effect. I could spend an entire workshop talking about criminalization and you equals you. There is still criminalization laws that are highly stigmatizing and not in pace with the modernization of HIV. And so there is a lot of work to do on that. We've got some fabulous people. Catherine Hanson's is one that is doing just some amazing work around criminalization. You need to be mindful of disclosure laws in your state. It varies from state to state, and so we always like to remind people about that. Here's the public health argument related to you equals you. If we could get everybody onto treatment, we could end this epidemic. And so we use you equals you as that health justice, as that social justice argument to encourage universal access to care. This is a series that is on our website, positiveseries.org, that's downloadable and customizable. So if you're looking for materials, this is a really great option. And then I'm going to conclude with Dr. Allison Roger.
Looks like we've got one more, and it has to come from you equals you himself.
Hi, Allison. Today is marking a revolution in what it means to live with HIV. So thank you so much for your research. I have a question on behalf of the You Equals You campaign. There are many providers that are still not accepting this message. They try to focus on the risk is not zero scientifically, or they focus on their patients aren't going to be adherent and they won't know that they're detectable, or they say there's a rise of STIs already, so they don't want to share this with their patients. We get every single kind of excuse. What would you say to clinicians or any other information provider who is withholding this information from people with HIV.
Yeah, and I just want to pay tribute to the U equals U campaign. It's been astonishing. I think the time for excuses are over. I think it's very, very clear that the risk is zero.
Dr. Allison Rogers was the lead author of Partner 1 and 2
So
studies.
I very much think we have to promote this. I think if you're on suppressive ART, you're sexually non-infectious, and yeah, the time for excuses is over. And I, again, pay tribute to you and your work. Thank you.
Now, I'm not going to play this. I have it, but it's not connected to the internet, I don't think. So this is Jacqueline Alisi. She was speaking at the international conference this last year. She said that U equals U is perhaps the most inspiring recent campaign in reality in the HIV history. It brings hope to so many of us, but most importantly, it brings the message that we are not disease vectors. Then she stopped and said, listen to this and let it sink in. We are not disease vectors, we are human beings. And it's very, very powerful. So with that, I'm just going to move through a few things that you can do to join and amplify this movement. It's an important stigma eraser, and we have a lot of work to do. Train your staff in communications, promote this prominently and consistently, communicate consciously, I talked about that, leverage the U equals U public health argument about access to care, speak out if you see incompetence or incorrect language, and connect to our movement. We'd invite you to join us. You can find us in social media with the hashtag U equals U. And we are, well, there's the information about the organization. So with that, I want to thank you and invite you to join the U equals U movement.
Thank you, Mr. Penner, for that important work as well. I'm noticing a theme around no more excuses. No more excuses. So, Dr. Dangerfield, you will come on up. Hopefully his theme will drive it home to that same theme as well, to no more excuses. Let's give him a round of applause, please.
No more excuses, okay. Good afternoon, really excited to be here, you guys. As mentioned earlier, I'm an assistant professor at the Johns Hopkins School of Nursing, and my research broadly targets ways to promote sexual health domains for populations of sexual minority men. And when I talk about sexual minority men, I'm referring to those guys who identify as gay, bisexual, queer, or other men who have sex with men who do not necessarily identify in those ways. This season, I'm working on a really cool study that was sponsored by NINR in a CFAW supplement from the Johns Hopkins School of University, actually, where we're doing a really cool project looking at age-related differences in HIV treatment adherence strategies for guys who have been undetectable for a long period of time. And one of the cool things that we're doing is this heavy ethnographic work where I've been hanging out in people's doctor's visits, going to people's houses, seeing where they keep the medicine, and how do people build that resilience to really reduce stigma within themselves, given that it's so prevalent and so salient and such a barrier to adherence. So I was invited to talk to you guys about some of the work that I do. We're going to talk about a life course exploration to some of these developmental pathways to sexual risk among Black men who have sex with men. So I'm really excited to share some of the work with you guys. How many of you guys are actually nurses? Okay. Do we have any other healthcare providers, physicians, social workers? Any members of the clergy? Okay. We have teachers, lawmakers, policymakers, lawyers. Okay. So I'm hoping that everybody can learn something from some of the work that we're doing. Now, I'm left-handed, so I thought this was going to help me. Okay, there we go. So we're going to talk about the importance of why we're reducing stigma among and improving health among specifically Black, gay, and bisexual and other sexual minority men. We'll talk about using the life course as a theoretical approach to HIV prevention and sexual health promotion activities. And we'll talk about some of the research that we did that was recently published in AIDS and Behavior, where we utilized this framework for health promotion among Black men. So for this international conference on stigma, I just want to highlight that the reason why we're focused on sexual minority men is, unfortunately, sexual minority men are the most disproportionately impacted group in countries of all incomes. And we're seeing in Africa, in Asia, in Southeast Asia, in the United States, and in Europe, and in South America, that sexual minority men are the most impacted group by HIV and the most disproportionately impacted in treatment outcomes. In the United States, in particular, men who have sex with men and sexual minority men are even further disproportionately impacted, right? So we know that they account for 70% of HIV infections, and we also know that they have accounted for 70% of all primary and syphilis, secondary syphilis infections. And you know syphilis and HIV go hand in hand. One comes right behind the other, or sometimes at the same time. Here's a more new, wait. Is somebody moving it? Here's a more nuanced lens at some of the incidents that we're seeing, and you can find this straight on the CDC's website. And this is infections amongst men who have sex with men by race and age. And what you can see is that the highest incidence by age among sexual minority men across ethnic groups is in that 13 to 24-year-old range and that 25 to 34-year-old range. So in my work, I've really been interested in the role of age and development. My question is it something about the developmental pathway, or since we've been seeing this trend in, the question I've had is it something about this age group that is developmental and impacting risk behaviors, or is it something about the lifetime that we're in, where infections the transmission rates are different, the information is different, the education is different, and the stigma related to same-sex relationship development is allegedly different. So now that we have the proliferation of same-sex marriage. So I'm really, really interested in seeing what is the role of age and development on risk trajectories for populations of sexual minority men, especially since we're seeing this distribution of infections by age being consistent over the past 5 or so years. But I'm particularly passionate and focused on Black sexual minority men in the United States because, unfortunately, despite the small proportion that they make of sexual minority men, they account for 40% of HIV incidents in the U.S. And we have some data that suggests, some modeling data that suggests that at current trends in prevention, treatment, and outcomes, that Black sexual minority men have a 1 in 2 chance of 50% lifetime risk of infection, which is absolutely horrific, despite the fact that compared to other ethnic groups, they're more likely to engage in less sexual risk behaviors, fewer partners, fewer drugs before and during sex. The modeling data still remains the same if we do not do something about trends in prevention and treatment for this group. But one thing that is important to note is that despite engagement in less behaviors, Black guys are more likely to report experiencing stigma, right? They're more likely to report anticipated stigma, internalized stigma, perceived stigma, actual stigma. And so it really becomes interesting to think about, the role of stigma as we talk about no more excuses, as we talk about how do we really, really proliferate some of the prevention messaging, and how do we really reduce some of this stigma and this risk factor for this group in particular. So these two questions not only guide my current research that I'm going to share with you, but these two questions really guide my entire portfolio. So what are the developmental pathways for sexual risk for Black sexual minority men? What's going on over the life course as folks grow, as folks develop? And how do psychological and social factors like stigma really affect sexual risk behaviors? And so life course theory has been a really useful tool in some of the work I do because it really guides us to think about how health behaviors and health outcomes like HIV are impacted by a cumulative effect between historical context, developmental context, and individual behaviors. And so, like I was saying, life course theory kind of guides us to think about how do generational differences in stigma, in treatment availability, in the availability of being able to develop same-sex relationships, how do those kinds of things that are different generationally really impact people's individual behaviors and their outcomes over the course of their lives. And so I've really been applying this framework to my work with Black sexual minority men, given that so much of the information that we have about HIV has shifted over the past 25, 30 years, and so much of the availability of same-sex relationship development and alleged stigma reduction has been most recent relative to older cohorts. And so what we did in Los Angeles was we did some in-depth qualitative life history interviews among 26 guys where we asked them all these life course related domains. So we asked them about how they grew up, their relationship to church, their relationship to their families. We asked them about all of their relationships over the course of their lives, their sexual behaviors. We asked them changes in attitudes towards themselves as same gender loving men. And we also created timelines of life events, and I'm going to show you one at the end that we did where everybody got a timeline to show themselves their life course, basically, relative to changes in the AIDS epidemic and relative to some laws and policies that were going on throughout the United States. Oh, you can't see this, but just quickly, the most important thing I just wanted to share is just the distribution of some of the data that we had where we collected the 26 interviews, and the age of the participants ranged from about 22 to 61 years old. We stratified them by age so we could get at some of these cohort differences that we're talking about. So we had about 10 guys who were under the age of 30, and then the rest of them were over the age of 30. All of them identified as gay or bisexual, so these are gay identified, bisexually identified men. We had 7 of the guys who did self-report that they were living with HIV. In this project, we teamed up with Reach LA in Los Angeles to do some of these interviews, and we also explored the feasibility of self-collecting samples for STI testing in a community-based setting rather than a clinic. So I was really excited that we were able to develop that partnership because we did find one participant who was diagnosed with chlamydia in our study who wouldn't have known that he had an infection because he was avoiding traditional healthcare facilities. Also of note from these data, I just want to also highlight that at the bottom you'll see, if you can see, that 40% of the guys in my project talked about a history of childhood sexual abuse prior to the age of 12 by someone, mostly a man, who was at least 5 years older than they were, which is a salient theme in the research. And as we talk about stigma, I also offer another layer of trauma that Black sexual minority men are experiencing that really, really does impact the developmental pathway to risk and health outcomes. So some of the findings that we had, just a quick overview. These data were published in AIDS and Behavior, so if you really are interested in reading the article to really see some of the quotes that we had, I'm happy to share that with you. I'll share my contact information at the end. But when we talk about these generational differences, one of the things that we found was how HIV prevention messaging and options impacted risk behavior. So older guys would say, they would say that they are engaged in risk because health information just wasn't available or treatment just wasn't available. So there was no way to, avoid infections. People were dying, and the messages about risk, about HIV were just not consistent, and the availability of treatment was limited, and so that had an implication of risk. Relative to the younger cohort of guys who were under the age of 30 who say, well, now AIDS is not a death sentence, HIV is not a death sentence, so there is an experience of less stigma of HIV from a younger cohort because of the proliferation of highly active antiretroviral treatment. So that information by generation impacted differences. Interestingly, guys also talked about how the availability to meet partners impacted their risk behavior. So the older cohort would talk about, well, yes, I was having sex in parks when I was young because we didn't have gay bars. We didn't have social venues to meet people. So when I was at a cruising park, there were no condoms. There was no lube. There was no you equals you. So those kinds of things impacted risk for the older cohort when they were young. And also, interestingly, the younger cohort talked about having the availability to meet partners and develop long-term relationships impacts a level of risk. So guys would talk about, well, yes, I have a lot of partners, but I'm trying to meet my husband. So when we're in the clinic, and this is why I love qualitative research. So sure, you have an allegedly large number of partners. If you screen people in the clinic and you say, okay, I have 10 partners. Well, some of the motivation behind that is contextual, right? So some people are saying, okay, yes, I have partners, but in order to meet the husband, now that I can meet the husband, I have to find out what he's working with. So this is what the guys are telling me in the projects, which is really, really interesting. And that level of nuance is really what we need to get at when we talk about some of these developmental pathways, and also how we characterize what risk is. So can we really classify people's intention to develop long-term relationships and the way they do that as risk? Or how do we really leverage some of the prevention messaging to really support sexual minority men in relationship development in a different type of way? And that's where my work is really trying to go. But across, why is this doing this? I'm giving it away, wait. Okay, but across, before I get to the timeline, because that is my favorite part, across age cohort, there were salient themes about how guys develop along their life course. So guys also, across all cohorts, guys talked about as they got older, behaviors and attitudes change. And we find this in all types of samples with women, with people who use drugs. We see that people's behaviors and their attitudes toward their health improve or change as they age, as time progresses. And that was true across cohorts in this project. But we also found that having histories of childhood sexual abuse was a really, really salient thing that kind of impacted people's pathways to risk. So some people would talk about how they were almost primed for relationships that were abusive or violent or emotionally dissatisfying because it re-triggered their feelings of victimization in their childhood. So it was a really, really, really powerful kind of self-revelation across cohort where folks were really think about how they ended up in situations that reminded them of their histories of abuse, or how they didn't feel empowered to make other kinds of decisions because they had histories of abuse, which is really, really, really important and powerful, and I think definitely an underexplored issue when we're talking about sexual health promotion for marginalized groups like Black sexual minority men. But really, really importantly and consistent with the literature, we did find that particularly church-based stigma, church-based homosexuality stigma really impacted guys' risk, and that's consistent in the literature. We definitely found the same thing, where guys would talk about having histories of homo-negative messaging in the church and negative messaging about HIV in the church really, really impacted their self-esteem, really impacted their sexual risk behaviors. And interestingly enough, and we wrote more about this in the paper, how because they couldn't find that quote-unquote soul food from the church, they were looking for it from the relationships. And so when we talk about the impact of stigma, I'm really, really encouraging us to really go a little bit deeper into what the impact of stigma is, particularly for Black sexual minority men, since we have such disproportionate outcomes relative to other groups. So So here's just an example of one of the timelines that we did, and we did this for every single person in the project, and we've been utilizing this as an intervention tool for nurses, where everybody gets a timeline, and I'm sorry if you can't kind of see it. It looks better in print. But in red, we highlighted the HIV care continuum, or the changes in HIV policy. So you'll see in the late 80s, where the timeline starts in the late 80s and it goes all the way to 2016, I think. So the CDC reported their first cases of what they thought was pneumonia, but it was really AIDS. Then we see in the middle of the timeline, highly antiretroviral therapy in 1996. We also talk about 9/11 in 2001. And this method and these kinds of events were really inspired by Sam Friedman's work with people who inject drugs, thinking about how changes in society impact risk outcomes, particularly when we talk about HIV. You see that in 2008, 2009, geosocial networking apps debut. Grindr hits the scene for the first time. The recession we also outlined from 2007 to 2009. And then you'll see towards the later end of the timeline, PrEP comes out, or is FDA approved in 2012. And then same-sex marriage is legalized in 2015 throughout the US. In the green is this particular individual's developmental pathway, and everybody gets this green developmental domain. And so we'll call this guy Derek, but I promise this is not me. So Derek is in his mid-20s, and he is born you mark the birth date, the birth year, but then that long domain at the top in green is how long he spent experiencing homonegativity from the church. Every Sunday in Bible study, on Wednesdays, he talks about being in the choir as well. And so he was growing up in the church, experiencing all these messages. And you can see how that is the longest history that he has among all the other domains in his life. Within that, what you're seeing is that right below that domain is how he talks about within the church, he's wrestling with feelings of same-sex desire, being attracted to other boys as he is a boy, and really struggling with those feelings. At the end of the domain where we're talking about the homonegativity from the church, below that in green is where he talks about, I left the church when I came out. So you can see the relationship between people's discovery of themselves, their acceptance of themselves, and their divorce from major institutions like the church, highlighted on this timeline. We also documented a few of his sexual partners. We weren't able to document all of them, but we did document some of them on the timeline. Toward the later end of the timeline, he talks about going to rehab for abuse of prescription painkillers and meth. However, once he ends rehab, he relapses, unfortunately, with meth, marijuana, and prescription painkillers. And in the blue, you're highlighting the sexual risk behaviors or the sexual partners. So everybody gets that blue domain too of where their sexual partners are that they could remember and identify in their period of lives. And so my research is really, really interested in targeting that domain where all those things coalesce, because what you're seeing is in yellow is where the infection happens. So in that same year where all those things happen, he reported a history of pharyngeal gonorrhea, syphilis, and when he came to my study, we were able to diagnose him with urethral chlamydia. So when we talk about stigma and health outcomes and developmental pathways, I've just really, really, really been excited to use this method, among others, to think about how do the events in early childhood and development coalesce through the life course to really facilitate that risk outcome right there. So it's not always HIV, it's not always gonorrhea, it's not always syphilis, it could be a mental health outcome, it could be something else. But really, really thinking about how do we mitigate some of these early developmental factors that really prime people for negative health outcomes. Does that make sense? You feel me? So for me, I'm just really encouraging us to continue to think about these age-related differences as changes in society are really, really happening. While we do have a long way to go, has been such substantial progress and huge, huge changes. Like to think that like you could have same-sex relationships legalized throughout the country, no matter how people feel about it. You know, definitely have that stigma present, but to have, you know, laws in place to protect sexual minorities is definitely interesting. The proliferation of U equals U is something that my older participants talk about. They never could fathom that was something that could be proliferated, and they grieve their friends and families who died of AIDS and weren't able to benefit from a lot of the treatment. So really thinking about age and generational differences. And I've been really encouraged and excited to increase nurses and healthcare providers' capacity to really understand how these trajectories unfold for sexual minority patients. We're headed in the right direction, but we definitely need more laws in place to protect from bullying against against youth in schools and violence in that way, and definitely need to really, really target that childhood sexual abuse. It's absolutely horrific, particularly when we're talking about Black sexual minority men. We really, really need interventions targeting people who have histories of that kind of abuse, and also mechanisms in place for prevention. My sample was not the only sample that had 40% of guys reporting this level of violence, which is absolutely horrific. Anyway, and as we talk about nurses and healthcare providers, what I've really, really been excited to think about is how do we really develop those trauma-informed care models where nurses, healthcare providers, physicians are really, really informed by some of the events in people's lives that might impact their patients' ability to access healthcare. But the last slide, I don't even want to touch it. There it is. If you're really interested in some of the work I do, please feel free to contact me, email me, and follow me and engage me on my Twitter at DT Dangerfield. Thank you.
Thank you, Dr. Dangerfield, for that. Lisa, I know we are maxed for time, but I wanted to know if we can take at least 5 minutes to just hold questions from the audience if they have any questions for the panel, if that works. Or I'll just make an executive decision and say yes.
One of our initiatives is ending the epidemic on what we called straight curious is a term they coined. They were saying that like it's basically men who have sex with men but don't identify as bi or gay, and they were wondering how to basically, for lack of a better term, bring them out the closet, decrease stigma, because they were associating that with increased risks of HIV transmission for African American women. I don't know if you had any insight on that, or we're seeing
about how to out people?
Or no, not necessarily that, but how to decrease stigma in that population. Yeah.
One of the things that that I've been thinking about is this thing of coming out, which we have underexplored. In the example that I showed, we had coming out as a one-time event in childhood, but actually you're always kind of coming out. Like every person you meet, if you're a sexual minority or if you're gay identified, you're always coming out. Everybody that you meet, you'll have to tell that you're gay or bisexual. So that process, I have empathy when I talk about the coming out process, because you can't encourage people to just do it once, because you have to understand that you're priming them to always do it after you tell the nurses, or actually after you tell your partners. You got to tell your friends, you got to tell your family, you got to tell everybody. So it's not a one-time thing. I say all that to say that I don't think we have a good grasp on how to do that, because I think we are talking about how to disclose to what we were talking about, what you were offering, of how to disclose to partners and how to disclose to providers. But how do you, the question is in my work, how do you support people along the course of their lives as they continue to experience these stigmas from people? And I don't think we have a good grasp on that yet. So, but keep going, but don't force nobody to come out if they're not ready to come out.
All right, so we have someone at the mic here.
So first of all, good afternoon, everybody. It's always a pleasure to be in a room, and thank you for the space to have this conversation. Most times I'm able to come into spaces and just be the public health expert that I am, but then there are other times that I have to come in spaces and be the activist and the advocate that I am. So I was looking through the program, and not one trans, non-binary, or gender non-conforming person was on the planning committee for 2019. And then you only have one trans masculine individual on the panel this afternoon. So I want to share with you that we cannot have a conversation about the etiology of HIV or stigma, because you can't end this epidemic without us. So when you begin to create spaces to have conversations about stigma, trans individuals being one of the most marginalized populations, when we talk about stigma, 311 trans individuals dead globally, 22 Black trans women murdered this year alone, and we sit on a stage and we talk about stigma when we don't talk about anything as it relates to the trans, non-binary, and gender non-conforming populations. You cannot continue to invite me in these spaces that are harmful, that are traumatizing, and that I am erased from the narrative. Now, we can continue to say that we don't have access. 10 years ago, we can say that we might not have had access to the trans, non-binary, and gender non-conforming population. But today there are experts across the country, qualified experts across the country, not just outreach workers, not just linkage to care specialists, but doctors, lawyers, doctorally trained nurses. And so we cannot keep having these conversations when I don't see myself represented in a room. I think we did ourselves a disservice for having an international conference on stigma when we had no topics related to the trans, non-binary, and gender non-conforming community. Because I assure you that if we're talking about the federal plan to end HIV by 2030, you can't end it without the trans, non-binary, and gender non-conforming communities.
Thank you so much for that information. I'm pretty sure we'll take that into consideration and continue to advocate to have a more diverse and equitable information shared at the next year's conference, or in the processes of being able to develop this type of platform. Thank you. Next question here.
Hi, my name's Pablo Molden. I am Youth Program Coordinator at Nova Salud. Been HIV positive for almost 11 years now, since I was 17, and received medically inaccurate sex ed in Northern Virginia at Fairfax County Public Schools. So 37 states provide medically inaccurate sex ed in the United States, where the laws don't require it to be medically accurate if it's taught. 44% of HIV positive youth in America don't know their status, and 22% of all new infections in 2017 were ages 13 to 19, and yet in the USCA conferences that I've been to, about 3 of them now, and the International AIDS Conference in 2012, I have never seen a workshop that was dedicated to sexual health and relationships education. I haven't seen it quite yet in the program for today. So my question is, what role do you think sex ed reform policy plays in ending the epidemic by 2030? Is it a priority in the HIV prevention, care, and education sector? Why or why not, and how can we prioritize it? Thank you.
My technology not working. Okay. So thank you so much for that. That is definitely where I am trying to go, especially when we're talking about early sexual development and teaching healthcare professionals and being in schools and thinking about how do we really support same-sex relationship development. So it's two domains that I think about when I hear that. The first domain is that, yes, we definitely need same-sex sexual health in schools. We need teachers and educators and curriculum to really understand the top and bottom dynamic and versatility dynamics and lube and condoms. That definitely needs to be in the literature and in the curriculum. But what I think is missing that we don't know how to do is really support same-sex relationship development. And I don't really know what that looks like because we haven't had long enough histories of being able to do that. And so I'm really interested in having an evidence-based practice of really studying long-term relationships and figuring out how can we develop curriculum to figure out what guys might even want from relationships, to even teach younger people about that. So I'm all about, especially being in nursing, I'm all about evidence-based practice. I'm not gonna share my personal thoughts about how we should teach folks to be in relationships. What we can do is think about a systematic approach to figure out what preferences are among youth and figure out how we can systematically teach youth the information that they want to hear rather than imposing our interests and our investments on them.
So I'll just add a little bit from the perspective of the context that I work in, and thank you for bringing that up. I think everybody is uncomfortable talking about sex. Not you. But I'm thinking about our teachers, our health workers, and actually in our stigma reduction program that I showed that we do with health workers, we have a couple sessions that are all about sex. We start with sex bingo, where we have people, answering questions about sexual practices and whether they've ever engaged in things. It's all anonymous, but we're really, at least in my experience in the context I work in, we're very uncomfortable talking about sex. And a lot of the HIV stigma, if we're honest about it, is about sex, particularly around young people, because we have a lot of baggage around young people having healthy sex or having sex at all. So I think we also need to think about how do we work with those who would they be providing the sex education, and how do we get people comfortable to do that?
All right, thank you. Thank you for your question. So we're going to take these last three questions, and then we're going to continue with the program. All right, I think I saw you first, and then. She was next. Okay, come on.
Hello, everyone. My name is Marty Kelly, and I'm representing, there's me and four of my friends were representing the mentally ill. And I've been hearing you talking about HIV and that, but what about the stigma of the mentally ill? I mean, there's a lot of stigmas going around about everything. I mean, I grew up with the stigma about being overweight, the mentally ill, and all this stuff. What do you think we could do to overcome the stigmas of those things?
Well, I'll just say you're absolutely right. There's stigma about a lot of things. And when we're talking about HIV, we're talking about a lot of syndemic issues, mental illness, we're talking about drug use, we're talking about sexuality, gender identity, all the different things that we're hearing. And so I think, I don't think there's a magic bullet. If we had a magic bullet for any of this, we wouldn't be having a conference on stigma, right? If we knew how to do this, we could really be there. There is so much to think about, but I'm going to bring it back to as it relates to HIV. I think that mental health counseling and treatment for people in ways that are compassionate is so critical to what we're looking at. I mean, we don't often pay attention to the things that people need support on to be able to be healthy. So we think about, well, why aren't they taking their medication or whatever, but we're not addressing homelessness, we're not addressing, mental health issues, we're not addressing substance use issues. And so we really need to be supporting people people, period, but people living with HIV with their entire lives. And I hear that as a theme all the time. And it's not really answering your question because unfortunately there's not a magic bullet to do it, but absolutely the attention needs to be there.
Thank you.
Hi, family. My name is Michael Lamb. Please feel free to call me Miss Mikey. And for you, ma'am, with your study with healthcare providers and healthcare professionals going into these spaces where they're providing care for somebody's life, somebody's body, and somebody's sexual and reproductive health, when you get this information back that 40%, 70% of them have stigmatizing or lackluster looking down attitudes at the people that they serve, do you present this information to the people that sign their checks, that make sure they have a good livelihood? And have there ever been like ramifications? Because while you have shown, after the intervention, their attitudes change significantly, while that's cute and all, that is still something that people could literally die over, because when they walk in to see the receptionist and they have the attitude and they don't even see this person's existence. So to tie all that in, has there ever been any ramifications after the intervention? Has people, actually been coached on certain things individually because they're, for lack of a better term, hate is just that strong, or ignorance? Because when we look at this stuff, when we look at this evidence-based information, it's very disheartening, because while that was happening where the study was, that's happening everywhere, and that's why people continue to be diagnosed with HIV and ultimately die. So that was my question.
Yeah, so I want to say that if you want to collect this kind of data, you can't put people's names to it because they're not going to answer honestly, okay? So you can't link that data to individuals or you'll never get it. The data is brought back to the management. As I explained, we develop the questionnaire with healthcare workers and clients, and then the data comes back to the facilities, and management is involved in looking at that data along with staff and clients and thinking through what are the positive things we can do to actually change the situation that we now see is in our facility, whether we like it or not. I mean, one of the fascinating things is we always bring back the data and we separate it by senior medical staff, regular medical staff, and admin. And the first thing we hear from the senior doctors is, well, that's gotta be the admin staff. And we're like, well, wait a minute, look at the tables. The tables are broken out by senior medical, and then there's a discussion, and eventually someone will say, okay guys, we all answered this questionnaire, we all know what goes on in our facility, let's own it. But you have to get people to that point where they're willing to admit that it's happening before you can actually move change forward. Now what's fascinating is, what I've learned over 20 years around stigma reduction is you're not going to get anywhere if you come in and say, you're doing bad things, stop doing that, whatever. You have to have a process that creates a safe space for people to reflect, to think, and to feel safe to propose change, but also to admit what's going on. And what's come out of that process, so these participatory stigma reduction trainings that we do, done by their peers, not by management, not by someone from the outside, very important, and with clients, is that there's this process that happens that changes things. And then the staff come together and decide what they want to do moving forward. Every single facility regenerated their complaint and compliment system. And so, they used a little bit of the money that we gave as grants to actually develop new boxes. And they actually put up signs that said, we pledge to do X, Y, and Z. If we're not doing this, here's the phone numbers and the names of the people you talk. And they have a process, these champion groups, where they open that box every week. So they're working to respond. The other thing is they're using the compliments as well. So this is important, what I was saying about you need to hold up the behavior that you want to see, not just telling people what not to do. And so one health facility, they actually every month in their health facility staff meeting, the staff and clients vote on who's had the best non-stigmatizing behavior that month. And they're just given a handshake and a clap, but they're held up in the facility, and that's nothing, it doesn't cost anything, but it has a huge effect. So there is accountability. A lot of the hospitals are also now integrating it into their performance evaluations and thinking through things like that. But it's important that that comes from within. It cannot be something that's imposed from outside or it won't work, is our lesson. Does that answer your question?
Thank you. Next.
Hello, I'm Commander Lucy Rivera. I'm with Prevention Through Active Community Engagement and in the HIV epidemic with the Office of the Assistant Secretary for Health. And my question is a follow-up question to the previous one. I'm interested to know, you measure what providers are seeing in behaviors from other providers. Will you able to measure what clients were saying about providers in a way to compare and see if those providers are self-aware of their stigmatizing behavior towards clients?
I want to make sure I understood the question.
Yes.
You're asking, did we measure among clients?
Yes.
Yes. So we did measure among clients, and we used that data particularly at baseline with the intervention to share it as part of the intervention. We did not have the resources to be able to do a large survey, so therefore we didn't have the power pre and post to look at. But if we looked at trends, we did see clients telling us that things had changed. What's interesting, not just from our data, but from data around the world, where we have both health provider, they're sharing their attitudes, but also what they're observing in their health facility, providers actually record a lot more stigma than the clients. So we're also, part of our challenge with the client data is that you're interviewing people at the health facility where they get their care, and are they going to feel comfortable, even though it's anonymous, et cetera, to actually say what's happening? Because this is, for many people, their only source of care. So we're a little bit, but in our qualitative work, we're definitely seeing changes. And we saw a lot from the youth in Tanzania. We had a lot of youth, and it was simple things like, my health provider doesn't sit on their phone while I'm sitting in front of them doing whatever they're doing and just letting me sit there. They don't do that anymore. They actually look me in the eye and engage me and actually take me on time. So things that we don't necessarily think about as stigma that you can actually, it's just quality of care that you can change with these kinds of interventions as well.
Thank you.
Thank you. Well, I want to thank the panel and thank everyone here for allowing them to be able to share this information. My hope is that you take this information and continue to have these courageous conversations around HIV stigma, these oftentimes difficult conversations around HIV stigma with your family, your friends, your peers, your clients, whomever, to be able to demystify or debunk this thing. No more excuses. Say it with me, no more excuses. No more excuses. Great, thank you.